Welcome to a new episode of Medicine in 3 minutes. As usual, we go straight to the point. The subject is bravely made clear and often illustrated. Today's topic is about pulmonary function test. Here's the roadmap of this presentation. A diagnostic of lung disease, lung volume static, dynamic condition, alveolar diffusion capacity, flow volume, UPS, pulmonary function test question, and spirometer prototype. Pulmonary function tests are used to differentiate between obstructive and restrictive disease, used equally to assess the severity of disease, used in preoperatoire to resect. As an example, if you have some lung cancer, even if it is chirurgically resectable, unless we prove on pulmonary function test that the extent is not severe, otherwise if FEV1 above 50% of predictable, we cannot operate. We have to do pulmonary function test as evaluation of treatment to recognize the efficacy of a drug and to document chronic disease. Let's start with static test. Regarding with statistics, otherwise static volume, we need only 3 volumes. The first one is the total lung capacity. The second one is the vital capacity, and the third one is residual volume. That's it. We need only 3 parameters to determine the function static test. I repeat, total lung capacity, residual volume, and vital capacity. Total lung capacity is the volume of gas in the lung after maximum inspiration. Vital capacity is the volume of gas exhaled with maximum forced expiration. The difference between them is the residual volume, which is the volume of gas remaining in the lung after forced maximum expiration. Total lung capacity after maximum inspiration. Vital capacity after maximum expiration. The difference is the residual volume. Here's the total lung capacity. Here's the vital capacity, and the difference between this and this, it's the residual volume. Otherwise, total lung capacity, volume of gas in the lung after maximum inspiration. Vital capacity is volume of gas exhaled with maximum forced expiration, and the difference between them is the residual volume. Now let's move on to dynamic test. Forced expiratory flow. When we determine expiratory flow and expiratory volume, we measure lung function under dynamic condition. Vital capacity against time is a dynamic condition. Forced expiratory volume 1 second if 1 second if EV1 over if VC is the best measure airflow in the lung. Allow to measure the trapped air in the lung. Allow to diagnostic obstructive lung disease. Two ways to measure obstructive disease. FEV1 over FVC, and the slope of the curve of FVC called forced expiratory flow, FEF 25%, 75%, which is an early predictor of chronic obstructive disease, COPD, known as small air obstruction, has a normal FEV1 and FVC. Here is an obstruction. FEV1 over FVC, it's around 40%. That means there is obstruction. In a restrictive disease, FEV1 over FVC, it's normal. Why? Because the FEV1 and FVC, they diminish in the same way. As a result, in restrictive disease, the ratio is the same. Obstructive under 80%, restrictive and normal around 80%. We can measure the forced expiratory flow, FEF, 25% as 75%, which is the slope of the curve. Bottom line, a restrictive disease, low total lung capacity, low residual volume, low vital capacity. Obstructive disease, low FEV1 over FVC, low FEF 25%, 75%, and sometimes elevate residual volume and elevate total lung capacity. Anything less than 80% of predicted is considered low. FEV1 less than 60% obstructive. Diffusion lung for carbon monoxide test, the LCO. It's a way to measure alveolar diffusion capacity. Here is emphysema, here is interstitial, here there is some fibrose, and here dilatation of alveoli. Emphysema, chronic bronchitis, and asthma, intersection is COPD. The LCO, it allows to make the diagnosis of emphysema regarding to chronic bronchitis and asthma. Diffusion capacity of carbon monoxide, the LCO. Emphysema is a permanent dilatation of alveolar membrane. Alveoli is destroyed and diffusion capacity is also decreased. Interstitial lung disease, there is fibrosis. Diffusion capacity, it's also decreased. In both there is a decrease. How to make the difference is with the DLCO. DLCO, there is a decrease in emphysema and interstitial lung disease. DLCO is normal in chronic bronchitis and extrapulmonary restriction. DLCO is increased in alveolar MRR. Let's recap. Restrictive disease, FEV1 over FVC is normal. Obstructive disease, FEV1 over FVC is low. Regarding restrictive disease, if the LCO is low, it's interstitial lung disease. Regarding obstructive disease, if EV1 over VC is low and DLCO is low, it's emphysema. If EV1, FVC low and DLCO low, emphysema. If EV1 over VC normal and DLC low, it's interstitial lung disease. DLCO normal mean extrapulmonary. It could be kyphoscoliosis, morbid obesity, myasthenia, Lambert-Eaton, or Guillain-Barré. Normal DLCO mean extrapulmonary disease, kyphoscoliosis, morbid obesity, myasthenia, Lambert-Eaton, and Guillain-Barré. If syndrome obstructive with normal DLCO, it could be asthma or chronic bronchitis. If DLCO is high, it could be alveolar hemorrhage, lupus, Wegener, and good posture. Methacholine test. When we give a patient methacholine, no matter the patient is, even normal person, that cause bronchoconstriction. A normal person get a little cough, but asthmatic person, because already predisposed, get a minimum asthmatic attack because he is hyperreactive. How to measure that? With pulmonary function test. Knowing the fact that asthma is reversible, outside the attack, pulmonary function tests are normal. What we do methacholine challenge test, which gives obstructive pattern typical of asthma. Positive test drop of 20% of predicted. But the test should be done under the control environment, hospital, because the risk of statute asthmatic. Asthma is a reversible disease. Outside the attack, pulmonary function tests are completely normal. We do methacholine challenge, which gives obstructive pattern typical of asthma. When the test is positive, there is a drop of 20% of predicted. Bronchodilatator reversibility. When asthmaticus, the difference between asthma, which is totally reversible, and chronic obstructive disease, which is by definition not reversible, the only way to make the difference is to give the patient a bronchodilatation, like albuterol, and see on the pulmonary function test if is it reversible by 20%, which is asthma. Otherwise, it is chronic obstructive lung disease. Flow volume loops. Flow volume loops express the relationship between flow rate versus lung volume in different lung processes. Obstructive pattern, fixed airway obstruction, tracheal stenosis, dynamic airway obstruction, and vocal cord paralysis. The normal curve, we start 0 from here. Here is the residual volume. Here is the total lung capacity, which around 5 liters. We are in expiration in green, and we are in inspiration in red, as the volume and the flow. The green color is the normal curve. The red color is the obstructive curve, and the gray color is the restrictive curve. Obstructive is shifted to the left. The residual volume is elevated. We start from here to here. Total lung capacity is shifted to the left, from here to here, because of air trapping flattened diaphragm. Curve peak early with prolonged curvilinear aspect. There is a prolonged curvilinear aspect. A response of bronchodilatator mean asthma. If this curve responds to the other, that's mean asthma after bronchodilatator. If there is no change after bronchodilatator, that's mean chronic bronchitis. What about restrictive? It is shift to the right. The residual volume is decreased. Total lung capacity is decreased. Curve is shifted to the right of normal curve because of air trapping flattened diaphragm. Curve peak early with prolonged curvilinear aspect. A response of bronchodilation mean asthma. No change is chronic bronchitis. The first model is obstructive. Here the normal, and the red one is obstructive. Prolonged phase air trapped. Residual volume is high, and sometimes total lung capacity is shifted to the left. Fixed obstruction. Regarding fixed obstruction, it's about tracheal stenosis or foreigner body. Patient cannot move air in the lung in and out. Here the inspiration, here the expiration. The green is the normal one. Dynamic obstruction, otherwise vocal cord paralysis. Fixed obstruction on one side, there is a fixed on one side. The bottom part looks normal. The bottom is normal, but it fixed in one side. It's the model of vocal cord paralysis. Pulmonary function test question. The first case, 1E, total lung capacity 87%, residual volume 120, it's increased, vital capacity 90% is normal, FVE1 over FVC 80% is normal, FVE1 25%, 75%, 50 is decreased. That means small airways disease. DLCO, patient 1A, 90%, it's normal. If DLCO normal, it could be asthma or chronic bronchitis. To make the difference, we give the bronchodilatator test, knowing that asthma is reversible. For the first case 2B, DLCO is decreased. That means emphysema. Second case, 1A, total lung capacity 55% is decreased, residual volume 50% is decreased, and vital capacity 50% is decreased. Everything is decreased. It could be a restrictive, kyphoscoliosis, morbid obesity, or neuromuscular Guillain-Barré, or myasthenia gravis. If DLCO is decreased 40%, it could be pneumoconios. Spirometry prototype. The ancestor of spirometry is spiroscope water. Right now, there is a flash pneumotake, Lily pneumotake, turbine statorotor, pilot tube, hot wire anemometer, and ultrasound. Hot wire anemometer measures the electronic resistance through a hot wire. Temperature is the wire drop when patient blows air in the spirometer. Static volume, 3 parameters. Total lung capacity increase, maximum inspiration. Vital capacity, maximum expiration. The difference, residual volume. And the rest in restrictive disease. All parameters decrease, but FEV1 over FVC is normal. For the expiratory flow, if 25% and 75%, the slope of the curve. A restrictive syndrome, FEV1 over FVC normal. If DLCO is low, interstitial lung disease. If DLCO is normal, extrapulmonary. Kyphoscoliosis, morbid obesity, myasthenia, Guillain-Barré, Lambert-Eaton. Syndrome obstructive, FEV1 over FVC low, DLCO low, emphysema. DLCO normal, could be asthma or chronic bronchitis. Give bronchodilatator to make the difference. DLCO high, alveolar hémorrhagie, lupus, Wegener, good posture. Obstructive, prolonged phase air trapped. Fixed obstructive, patient cannot move air. Dynamic obstruction, vocal cord paralysis. Fixed obstruction on one side and normal at the other side. Thank you for watching this episode of Medicine in 3 minutes. Make sure to push the button like and subscribe. Your comments are very welcome.